Hello, my name is Rachel Owusu-Lewis. I am an internal medicine resident at Sinai Grace Hospital. My case is regarding a young pregnant female who presented with paradoxical embolism, hence the title, Acute PE and Stroke from Paradoxical Embolism, a management paradox. Damned if you do, damned if you don't. Although we are aware that the risk of thromboembolism is much higher in pregnancy, it is of note that it increases up to fourfold and is associated with 70,000 maternal deaths per year worldwide. So a little bit about the case. This is a 37-year-old female who at 6 weeks gestation presents with left upper and left lower extremity paralysis, sensory loss, left-sided neglect, as well as slurred speech. The patient was brought in by her mother, who noticed that she was minimally responsive and also weak. She was ANO times 3, albeit lethargic on presentation, and only reported a minor headache, but denied blurred vision, dysphagia, chest pain, or shortness of breath. Past medical history, she denied. Past surgical history, a cesarean section 3 years prior. Patient also denied tobacco use, alcohol use, recreational drug use, and she worked as an interventional radiology nurse. She was allergic to Tylenol, denied any medications, and has a family history of diabetes in her mother. Vital signs were stable except for tachycardia. Labs showed a sodium of 133, glucose of 239, BNP of 890, troponin 350, INR 1.12, and HCG 24,000. Imaging, which you can see in the middle of the page, showed a CT head and brain without contrast, as well as a CT head perfusion scan, which is not pictured, which revealed a large area of right MCA ischemic changes. CTA head and brain with contrast, CTA neck with contrast, showed the above, but also a saddle pulmonary embolism at the pulmonary trunk, bifurcating, extending into the pulmonary artery, which was confirmed by a CT thorax, which is noted in image A. The patient was not a candidate for TPA because she was out of the window. She was not a candidate for ECOS, surgical or mechanical thrombectomy, due to the need for full anticoagulation and the concern for hemorrhagic conversion. A catheter-directed thrombectomy is not a procedure that is available at our institution. So the patient was started on IV heparin drip. A paradoxical embolism was suspected and confirmed by a 2D echo bubble study. Lower extremity bilateral venous duplex ultrasound was negative for DVT. IV heparin drip had to be discontinued on day 4 after a repeat head CT showed hemorrhagic conversion, but it was restarted on day 6 when repeat CTs showed that the hemorrhage was stable. And 7 days after admission, a repeat bilateral lower extremity venous duplex revealed an acute DVT involving the right common femoral, and popliteal veins. On day 7, unfortunately, the patient acutely deteriorated, went into cardiac arrest, and expired after ACLS. The management of pulmonary embolism with stroke from paradoxical embolization requires a delicate balance of the risk of intercerebral hemorrhage from anticoagulation with the risk of hemodynamic collapse. The risk of thromboembolism in pregnancy increases with increasing age, obesity, multiple births and gestations, thrombophilia and thrombocytopenia, SLE, heart disease, migraine headaches, sickle cell disease, and hypertension. The complication rate of thrombolytics is very similar in the pregnant versus non-pregnant female. Age, infarct volume, and estimated glomerular filtration rate predict the hemorrhagic conversion. Thank you.